All right. And we're live. Welcome, everyone. We're going to give everyone just a few more minutes to log in. We're a little early, so come on in. As you're waiting for everyone to join, I wanted to bring to your attention that next week is Nurses Week giveaway. So Archer is giving away a lot of cool things. I wish I could participate, but I can't, but you guys can. So I wanted to bring it to your attention. But definitely follow us on social media. You can use this QR code, but we're giving away things like stethoscopes, Amazon gift cards, DoorDash gift cards, a Figs gift card. I really wish I could participate because this is going to be an awesome week of giveaways. So follow us on our Instagram page. Just go onto the QR code and you can do that while we're waiting for everybody to join us. So come on in and we'll get started in just a few minutes. All right, looks like we're at the top of the hour, so I'm going to get us started. So as people are joining, everybody can participate in this poll that I'm about to launch. But I basically want to get us started on getting to know the audience a little bit better. So tell me if you're currently an FNP student or maybe a different nurse practitioner track. And if you are still a student or if you've graduated and you're waiting for the boards, let me see if I can launch this poll for us today. And it was just allowing me to do it here. Let's see. Let's launch it. There we go. Okay. So go ahead and answer this quick poll for me as people are joining. I'm going to give you all a few minutes to answer. And if you missed it, if you just joined us, I also was bringing your attention to the nurses giveaway week. Next week, Archer's giving a lot of cool stuff away, like gift cards to Figs and Amazon gift card and what else? DoorDash, stethoscopes, so a lot of good stuff. So follow us on our social media page on Instagram, and you will be eligible to get all those awesome prizes. But it looks like I'm going to give a few more minutes for the poll. Just let me know where you're at in your FNP or in your nurse practitioner journey. Are you a current student? Have you graduated? You're getting ready for the boards? Just 3 quick questions. 5 quick questions. And then we'll get started. Okay, looks like most of you answered, so I'm going to go ahead and end the poll. Thank you so much for answering. And we're going to get started. It says share results. I think that shares it with everybody else. So I'm going to stop sharing it and end it right there. Very good. Well, thank you again for joining me today. Today, we're going to do part 1 of 2 parts in our endocrine series. We're going to mostly focus on the thyroid today and a few other endocrine disorders. Next week, we'll do diabetes. That's a much bigger topic. So we're going to give a full hour to diabetes, talk about both type 1 and type 2 and all the medications that you'll be prescribing and managing. So today, we're mostly going to focus on thyroid and a few other endocrine disorders. Endocrine, it's a huge system, right? It consists of tissues, mainly glands that create and release hormones. So your hormones are the chemicals that help coordinate different functions in your body. And these signals tell your body what to do and when to do it. So your endocrine system is pretty important, right? Today, like I said, we're going to mostly focus on the thyroid, parathyroid. We're going to talk about the adrenal glands, but this is definitely something that you'll encounter both in clinical practice in your boards because it just is all encompassing. And so as we're going through the PowerPoint today, as always, we like to keep it really informal. So I'm going to ask you a lot of questions. So keep that chat box open. We have our lovely Morgan helping us on the chat today. But I want you to try to answer those questions because this is the time for you to make mistakes, ask questions so that we can work through it so that you get it right on your boards, right? So don't be shy. I want you to be, loose and relaxed and interactive with me today. And I have a lot of good stuff for you. So let's get started. So again, with the overview of the endocrine system, the main function of your endocrine system is to release those hormones into your blood. So it releases the hormones, but it also simultaneously monitors those levels. So it's doing a really hard job, right? You have over 50 different types of hormones in your body, and it affects all aspects of your health, both directly and indirectly. Some examples of that is it helps with metabolism. Homeostasis, that's a big one. So it helps regulate things like blood pressure, blood sugar. That's why we have that big topic, diabetes, next week. It also helps things like electrolyte balance, body temperature, and then it also helps with growth and development. So we'll talk a little bit about that too. But remember, endocrine disorders also are in our pediatric population. That's something we want to watch out for. Sexual function, reproduction, our sleep-wake cycle, our mood. So it really touches the whole body, right? So it's something that you want to get comfortable with. You're going to see it in the clinic and on your boards. Hypothyroidism, I'm going to spend a lot of time talking about hypothyroidism because in primary care, this is going to be the majority of your practice is with your hypothyroid patients. You're going to get really comfortable with managing these patients. As you get into more complicated endocrine disorders, they will be co-managed by you and an endocrinologist, mostly the endocrinologist, but you should be aware of what the endocrinologist is doing and recommending because you are their primary care provider. But for hypothyroidism, most patients feel comfortable going to their PCP and not having to see an endocrinologist just for hypothyroidism. So you're going to get really comfortable with managing that. So first, before we go into that, a little anatomy physiology. So I always say this in all my webinars. So if you've joined me before, you probably have heard me say this, but always know your anatomy and physiology, right? That was the best piece of advice I got when I started practice or started my FNP journey. And it's really been true to today. So if you know your anatomy physiology, then you're going to know your pathophysiology. So if you know your normal, you'll be able to identify abnormal a lot more easily and you won't miss things. So know your normal. So what is normal? So the thyroid gland, it gets stimulated by that thyroid stimulating hormone. The pituitary gland releases a hormone, which then activates that thyroid stimulating hormone. And that thyroid stimulating hormone is basically just stimulating that thyroid gland to produce more thyroid hormone. Your thyroid hormones are your T4 and your T3. The thyroid gland also releases calcitonin. And then how does it know how much to release in the body? That's your negative feedback loop, right? So based on the levels of your thyroid hormone, that T4 and T3, it's going to signal back to the brain, back to that pituitary gland to either release more or less of that thyroid stimulating hormone. So that negative feedback loop is really important. In the endocrine system, you have a lot of feedback loops. Again, it's constantly monitoring the levels of the hormones that are released in the bloodstream. So there are a lot of feedback loops in the endocrine system that's the way it actually regulates what the levels are, and it knows how much to release and when to release it. So with hypothyroidism, so hypo, we're talking about an underproduction of those thyroid hormones, right? So it's not enough T4 and T3. What that leads to is an elevation in that TSH and that thyroid stimulating hormone. So most of you know that by now, but the reason why I bring it up is because your patients are going to come to you with their lab values and they're going to be really confused. They're going to say, wait, I thought I had hypothyroidism. I thought I had a slow, sluggish thyroid. Why is my TSH elevated? Does that mean I'm cured? Or what does that mean? Does that mean I have an overactive thyroid? So you have to get really comfortable with explaining this to your patients and walking them through what they're seeing on their lab values. So letting them know that that thyroid stimulating hormone is not actually their thyroid hormone, but that's stimulating their thyroid. So there's a reason why it's elevated because their thyroid is sluggish. It is hypothyroid. It's underactive. And so the brain is continuing to try to stimulate that thyroid. So they're going to see elevated levels of that thyroid stimulating hormone and low levels of the T4 and T3, which are their actual thyroid hormone. There are different types of hypothyroidism. You're mostly going to be managing the primary hypothyroidism. Hashimoto's is the most common cause of hypothyroidism in the United States, and iodine deficiency is the common leading cause globally. That might come up in your boards, hint, hint. So think about that. There are other causes of primary hypothyroidism, and then secondary hypothyroidism is when there is a problem outside of the thyroid gland. So primary, the thyroid gland itself is the problem. Secondary, it's a problem outside of the thyroid gland. So it's due to the pituitary or hypothalamic disease or damage. There are universal symptoms that you're going to see with hypothyroidism. Patients are going to come in with fatigue, constipation. They're going to see changes in their skin, hair, nails, maybe some weight gain, a lot of mood changes. So they might have increased anxiety or depression. They might have some cardiovascular symptoms if it's been untreated for a long time. And then I wanted to highlight again that slow growth and delayed puberty. So we want to be thinking about this in our pediatric patient population as well. So asking those questions about family history and then watching that growth chart, right? So if you joined me last week in that pediatric review, we want to watch their growth curve on that growth chart. There are different, like I said, there are different types of hypothyroidism, and then it could also be overt or subclinical. So in a patient where they have overt hypothyroidism, they definitely have some of these clinical features and characteristics, and then you're going to confirm it on the lab value. Their TSH is going to be elevated, low T4, T3. In a patient who's subclinical, this might be a patient that you picked up on it, like if you threw in a thyroid panel for your annual labs, and you see a slight elevation in their TSH, but they don't have any symptoms, they're feeling well, normal thyroid hormone levels, this might be a patient you want to watch. And if you want to ask more questions, right? So do they have a family history of autoimmune diseases? Then you might want to consider checking their antibodies to see if they're positive for Hashimoto's. And again, it would be a patient that you'd want to watch because they're asymptomatic, right? And their thyroid hormone levels are normal. So you're going to watch and wait and test them probably annually to see if they develop into more of an overt hypothyroidism that needs to be treated. So again, history and physical is going to be really important with these patients. They're going to come in with, it's usually pretty vague symptoms, but it always sounds about the same. I have difficulty losing weight. I can't seem to lose weight. I do exercise. I eat well. I'm always tired. I can't seem to really think clearly or concentrate or focus. They might have constipation. With that, when you're going to, in hypothyroidism, when they say constipation, you're going to see in patients, especially in patients who have been undiagnosed for a long time, they're going to have really bad constipation. Like they cannot go without using some sort of over-the-counter treatment, or they have to really get some assistance to go to the bathroom. So it can get pretty bad if it's due to their hypothyroidism. You might see some thinning of the hair too, some hair loss. We're not talking about alopecia chunks. We're talking about just thinning of that hair. And again, with some mood disorders, you want to be thinking thyroid in the back of your mind. You want to rule that out because we do see a lot of increased anxiety and depression in those patients, and definitely some temperature sensitivities. And again, with those cardiac symptoms, if it's pretty advanced. On your physical, you might find a goiter, so an enlarged thyroid gland. You want to get really comfortable with palpating thyroid so you know what normal feels like, so you can feel what abnormal feels like. Sometimes it'll be really obvious. I had a patient a couple of weeks ago where she had a pretty large goiter and didn't tell me when we were doing our physical. She was wearing, a turtleneck. And I was going through our history questions, new patient, and then I get to my physical and there it is. Turns out she has an endocrinologist who's been following her, and she omitted all that from the history questions, but you will find those cases. And so on your physicals, you want to make sure you're doing a thorough job always palpating that thyroid gland to see if you feel for anything. In patients with really advanced disease, you're going to see some pallor, slow movements or speech, that flat facial expression. And again, in our pediatric population, we really want to watch those growth charts, right? Are they hitting puberty within the right time frame? Are they growing along their growth curve? So that's going to be really important. And then with treatment, so the treatment for hypothyroidism is then synthetic thyroxine, which is T4, which is levothyroxine. So it can either be generic or brand levothyroxine, and the brand is Synthroid. Synthroid can be pretty expensive. There are a lot of different pharmacies that don't take insurance, that you pay an out-of-pocket cost, and that could be a little bit less for the patient. But typically patients will do really well on generic. So you always want to start them on generic. And then if you're having a patient where you just can't get their thyroid levels within goal, then you might want to try brand Synthroid to see if that'll help. Sometimes what I tell patients is just like with any brand versus generic, brand sometimes has more consistent amounts of the medication, and some patients are just really sensitive to it, so they do need the brand. But just remember, it can get really pricey for the patient, so keep that in mind. The goal for your treatment is to get that patient to a euthyroid state, meaning their thyroid hormone levels are within a normal range, and you're helping relieve that patient's symptoms, right? So they're feeling a lot better and their thyroid levels are within normal range. Oftentimes you'll get their thyroid levels within normal range, but the patient says, I still have difficulty losing weight. I'm still tired all the time. So then you have to explore other things that could be causing that. Do they have sleep apnea causing more fatigue? It's not likely their thyroid that you've now treated and gotten under control. But basically with initial dosing, you want to take into account age and weight. It is age and weight based. Please start slow and gradually increase and adjust about every 4 weeks. And before you adjust, you do want to check those thyroid levels, right, after you make an adjustment, just to see where you're at. You can do a dose adjustment about every 4 to 8 weeks. We, in our practice about every 4 to 6 weeks. That's fine. So you'll kind of get a feel for your clinical practice and how they like to do it and how your group practices in the community. And then making sure you're counseling patients on how to use the medication is going to be really important, because levothyroxine does have a lot of interactions. The way it works in the body is it gets absorbed through the acid in the stomach. So if you're taking things that affect or change the acid in the stomach, it's going to affect the absorption of the medication. So making sure that you're educating the patient to take it 30 to 60 minutes either before breakfast or 3 to 4 hours after dinner. A lot of patients are rushing out the door, or they can't wait that 30 to 60 minutes before they eat breakfast. They're really hungry, especially our pediatric patients. If they wake up really hungry, it might be better to have them take their medication right before bed, just making sure you've spaced it out about 3 to 4 hours before after meals, so that it is still on an empty stomach. And then hint, hint, you want to definitely make sure you're taking a thorough history of their medication. What are they taking, including over the counters, right? And you want to avoid coupling it or taking it with iron, calcium, antacids, or PPIs, at least within 4 hours of taking the medication. So make sure you keep that in mind. And then for our pregnant or lactating females, they do have a higher dose requirement, because remember, in pregnancy, baby doesn't start making its own thyroid hormone until week 12. So you're going to expect to follow these women a lot more closely. They're likely going to be managed by endocrinology, but you might be getting them started and then waiting on endocrinology to take over. But you want to definitely keep an eye on these women at least every 4 weeks, checking their levels and making dose adjustments as appropriate. And then same with our lactating mamas, because they are nursing. So let's practice. And I want you to get those chat boxes out like we talked about. And we're going to walk through these. So please don't be shy with answering. Give it a try. This is where you want to make the mistake, and we will definitely talk through it. So a patient has been diagnosed with hypothyroidism, and the nurse practitioner is beginning levothyroxine or Synthroid, 25 micrograms, right? In review of the patient's current medications, which of the following will require specific education for use concurrently with levothyroxine Synthroid? So which one do you see on their med list where you're going to talk to them about making sure they know what they need to do and how to take that medication with the levothyroxine? Is it A, Prilosec, B, Lexapro, C, Lipitor, D, Zestrol or lisinopril? Let's see what you guys have to say. Okay, I'm seeing a lot of right answers. That's great. I'm seeing a lot of participation. So as I say to my kids, it doesn't matter if you get it right. What I care about is that you tried. So all right, you guys all got it right. So A, exactly right. You're listening. I love it. And you're going to educate your patients on this because you're going to know about it. You're going to get it right on the boards. So you definitely want to make sure you talk to that patient about avoiding that PPI, right? The Prilosec with their levothyroxine. So making sure they separate it at least by 4 hours so that it doesn't affect the absorption of the medication. Lexapro, Lipitor, lisinopril, none of those medications have any interaction with levothyroxine. I generally like to have patients still separate their medications. So I tell them if you take your thyroid in the morning, thyroid medication in the morning, just take your other medications at nighttime. That usually works out better if they're on a statin because it's more effective at night, or vice versa. If they like to take their medicines in the morning with some food, then take that Synthroid on an empty stomach at bedtime. Okay, awesome job. Moving on to the next one. The nurse practitioner knows that congenital hypothyroidism must be identified quickly after birth to prevent irreversible neurological effects. Which of the following is the standard of care that has helped identify diagnosis earlier? Is it A, pulse ox, B, thyroid ultrasound, C, newborn screening, D, hearing screen? So I'm going to give you guys a few minutes. And if you participated last week in our pediatric series, you'll remember, well, I almost gave the answer away. I'll tell you in a minute. Okay, I'm loving the participation. Good job, you guys. So yes, so that newborn screen. So what I was about to say is if you participated last week in that pediatric series, you'll remember that that newborn screening happens in the hospital, right? And each state does their own newborn screening. Find out in your state whether they do the thyroid screen. They most likely do, because that's pretty universal now. In my state, we do. And so the whole point of that newborn screen, of pediatric screening and milestones, is to catch things early, to prevent, right? Prevention, prevention, prevention. So we want to make sure in that newborn screening, they are going to run the thyroid panel and make sure that we're catching congenital hypothyroidism and starting treatment early so that we prevent any issues for that baby, right? And then the pulse ox is actually going to be the screening to identify congenital heart defects. And then the thyroid ultrasound is not really it's not the best way to identify the congenital hypothyroidism, even though you can use it to look at abnormalities in that thyroid gland. So they might choose to do an ultrasound depending on their suspicions in the exam. And then that hearing screen, of course, is to identify for any congenital hearing loss. So good job, you guys. It's that newborn screen has that thyroid panel in it. Awesome job. Okay, so which of the following causes the majority of hypothyroidism in geriatric patients? Is it A, autoimmune thyroiditis, B, post-surgical, C, post-radioiodine, or D, secondary thyroiditis? So which is the most common cause of hypothyroidism in the geriatric patient? But you're guessing, Young Ho. I like it. That's good. You can put a question mark at the end of your answer. I like it. Good, Madison. Keep going, you guys. Put your guesses in. Don't be shy. Awesome, Libby. Okay, so this is a tricky one just because of the way it's worded. So I was being a little evil with this one. I'm sorry, but I'm having fun. So the correct answer is A. So the majority of hypothyroidism, remember we talked about the majority of cases of hypothyroidism in the United States is Hashimoto's, right? Autoimmune thyroiditis. So this didn't write Hashimoto's, it just said autoimmune thyroiditis, but that is the most common cause in the United States. And then it kind of threw a curveball at you. It said geriatric patients. So you thought maybe something else was more common. Nope. It's the most common is Hashimoto's, autoimmune thyroiditis, across the board in the United States. And then do you guys remember what the second most common, or sorry, what the most common outside the US was? Do you guys remember that? Throwing another question in there. I said it. Yes. I All right, very good, you guys. And then so post-surgical, post-radioiodine, secondary hypothyroidism, those are all other possibilities of hypothyroidism, but not the most common. So you guys got it right. Good job. Okay, so moving on to hyperthyroidism. So we're going to go back to that negative feedback loop. Remember, always go back to your anatomy, physiology. So in hyperthyroidism, what's happening? It's an overactive thyroid gland. So you're going to have a high level of thyroid hormones, T4 and T3, and that's going to signal back to the pituitary gland, hey, we've got a lot of thyroid hormone. Let's slow it down with stimulating that thyroid gland. So you're going to have low or suppressed levels of that thyroid stimulating hormone. So that's how that loop is going to look for hyperthyroidism. So it's an overproduction of the thyroid hormones. So those levels of TSH are going to be low or suppressed. There are different types of hyperthyroidism, just like in hypothyroidism. You're going to have primary and secondary causes. So primary causes with the actual thyroid itself, secondary with the pituitary or the hypothalamus causes like pituitary adenoma. The most common cause of hyperthyroidism in the Western hemisphere is Graves' disease, okay? So keep that in mind. It's also an autoimmune disorder. It causes overproduction of that thyroid hormones, which leads to increased metabolism and hyperadrenergic state. There are also other causes of primary hyperthyroidism that you might see, like multinodular goiters, solitary toxic thyroid nodules, which we'll talk about a little bit, thyroiditis, thyroid cancer. So there are also other kinds of primary hyperthyroidism, but the most common is Graves' disease. Some of the universal features of hyperthyroidism, so all of them hyperthyroidism, you're going to see irritability, sweating, heat intolerance, tachycardia, weight loss, maybe frequent stools, because remember, it's that increased metabolism and hyperadrenergic state, right? To confirm your diagnosis or to start the initial diagnostic process, you're going to get that thyroid panel and take a look at the TSH with the T4 and the T3. But really, you're going to refer to an endocrinologist if you're seeing a suppressed TSH with high levels of T4, T3, so they can investigate the cause. You could order the antibody testing, which is specific for Graves if you want to confirm Graves. But the endocrinologist is going to do more specific testing, like a radioiodine uptake scan, just to see the hot and cold spots. They'll probably also do a sonogram to evaluate those nodules, especially in multinodular goiters, just to make sure there are no concerning nodules that they have to keep an eye on. So for your purposes in primary care, you're most likely just going to start the initial workup and then refer to endo to investigate the cause. What you might have to do in primary care is manage that patient while they're waiting to see endocrinology. And so we'll talk a little bit about that. But basically, Graves' disease, since it's the most common, right? I want you to get a little more familiar with Graves' disease. You might see this on the boards, but you can see more specific clinical features of Graves' disease. You're going to see a diffuse goiter without any nodules. So it's not that multinodular goiter that we're talking about. You might see thyroid disease. So you might see the bulging eyes, right? And then it's also associated with a skin condition on the lower legs. But it's the same as all the other hyperthyroid causes, right? And then I wanted to flag thyroid nodules because these are really common. You're probably going to pick up on some in primary care and refer over to endocrinology to investigate, but they're very common and the majority of the cases are benign and found incidentally, like on your physical exam. But they should still be monitored for malignancy and growth. You shouldn't ignore them, but you want to make sure the patients are aware that it's, very common. About 50% of our population do have some thyroid nodules that just have to be followed, and they're the majority of the time pretty benign. What you would probably do is order that thyroid panel to investigate and then send them over to endocrinology, and they'll probably do a thyroid ultrasound. Depending on that and the history and their physical exam, they might want to do other testing or potential interventions. They might want to biopsy it and talk about other interventions as needed. But for you in primary care, don't be afraid to palpate that thyroid and identify those thyroid nodules, because you definitely want to monitor them and not ignore them. So that's important. So the treatment for hyperthyroidism, like I said, most of this is going to, management is going to depend on the etiology and the severity of symptoms. So most of this is going to be managed by endocrinology, but you may have to get this patient started while they're waiting for endocrinology. And you in primary care should also be aware of the treatment plan so that you can work with endocrinology and work with your patients to make sure that they're getting the care that they need, right? So most of the times these patients are going to be on a beta blocker to help with palpitations, anxiety, maybe they have a tremor. So you might have to start them on that beta blocker while they're waiting. There are also 3 definitive treatment plans that the endocrinologist will talk to them about, and they'll decide with their endocrinologist which is the best treatment plan for them. Radioactive iodine therapy and antithyroid drugs and thyroidectomy are the 3 categories. For you, for your boards, you're going to want to know your pharmacology, so your antithyroid drugs. Most important thing for you is to know the contraindications. So methimazole is contraindicated in pregnancy. Like I said, because endocrinology is managing these patients, you're not starting this patient on methimazole, likely not starting this patient on methimazole. You're probably not going to be treating them, switching them to PTU either. But if you have that patient, young patient coming and say, you know, I want a family in a couple of years, and they're starting that conversation with family planning, then you need to direct them back to their endocrinologist to have the conversation so that they could talk about other treatment plans. Because maybe for them, it makes more sense to have radioactive iodine therapy where they have to then be on a T4 agent for the rest of their lives, or thyroidectomy, because that's going to be lower risk to them and baby. Maybe they want to stay on antithyroid drugs, but switch to another agent that's not contraindicated in pregnancy. So you need to be aware of those contraindications, and the board is always going to ask you safety questions. So know that methimazole is contraindicated in pregnancy. But again, for hyperthyroidism, the treatment, you're going to refer to endocrinology. You want to make sure that they're getting their routine eye exams, because remember what we talked about with Graves' disease, you're going to have that thyroid eye disease. So they have to be making sure they're going to their ophthalmologist. You can also ask them questions about whether they can close their eyes and keep their eyes closed at night. So you want to look for dry eye and any issues due to their thyroid eye disease. And again, direct them back to their ophthalmologist. And then, of course, flag for any urgent referral. So if you are seeing anything more acute, that you're sending them to the right places. So if they've developed an arrhythmia because of their hyperthyroidism, they're having chest pain, if they've developed heart failure, I mean, these are pretty advanced, but you want to be able to identify when it's beyond your scope, right? And to get them the care that they need. And so coming to that, I wanted to make sure you guys were aware of thyroid storm and what it was, because you might see this in the clinic. You might have a patient coming in feeling this way, and when you take a history, you see that they have a history of hypothyroidism or hyperthyroidism, and then you're suspecting it should be on your radar thyroid storm and getting them to the proper care that they need, right? So what is a thyroid storm? It's basically the effects of excess thyroid hormone on the body, but magnified. So it's a pretty rare presentation, but it is acute, it is severe. So it's going to be your hyperthyroid symptoms, but magnified. That's a good way to look at it. So the patient's going to come in distress. They might have a fever, really tachycardic and sweaty. They might feel really anxious, didn't sleep the night before. In really bad cases, you'll see some confusion, delirium seizures. I mean, you already know, straight to the ER with all that. But if you are suspecting it, then you definitely want to make sure that early intervention is key, because we have this little mortality rate up here that's really depressing. But again, just know that this is a rare condition. If a patient's acutely distressed like this, then you're going to send them to get that prompt intervention and management that they need. And some triggers that you might want to identify. So if a patient is hyperthyroid and they've abruptly stopped taking their antithyroid medication. So we do have a lot of patients who do that. They don't feel great when they're on the medication. So they think, okay, I feel fine without it. I'm going to stop taking my medication. And then all of a sudden they get themselves into trouble, right? So you want to definitely take a thorough history. Are they taking the medications that they're supposed to be taking, that their endocrinologist thinks they are taking, right? Are they taking too much thyroid hormone? So I've seen patients who are hypothyroid who are getting overtreated because they didn't realize that it's weight dependent. And so they lost a lot of weight because that was part of their New Year's resolution, or that was one of their goals for the year. And they're doing a really good job losing weight, but they haven't gone back to see their endocrinologist or whoever's managing their thyroid medication. It might be you even, and getting their labs redrawn to make sure that they're not getting overtreated, right? So that's going to be big thing to look out for as well. And then there are, of course, other triggers and stressors like childbirth, infection, surgery that can also trigger a thyroid storm. So just something to keep in mind. Again, they do need to go to the hospital because they are going to need some supportive care. Probably they're going to need antiarrhythmic drugs, beta blockers, fluid resuscitation. So it's important to get them to the hospital quickly. All right. So how might you see something like hyperthyroid on the exam? What do they want you to know? So again, they're going to want you to know safety, right? So a 32-year-old patient presents to your office with complaints of unintended weight loss over the last 2 months, palpitations, thinning hair, insomnia. So it's all sounding right. As she is speaking to you, you note that her eyes seem to protrude. So look at the picture. She has the eye disease. And then her vital signs, you look at it and blood pressure's a little elevated, heart rate's definitely elevated, respiration's good, temperature's good. What diagnostic tests do you consider to further assess her symptoms? Is it a thyroid panel with a TSH and thyroid hormones, T4, T3? Is it an electrocardiogram? So an EKG, a Chem7, so your Chem panel, or estrogenic hormone test. So what are you thinking to further assess these symptoms? Yes, everyone's getting it. Good job, you guys. So you should be thinking as top of your differentials, you should be thinking overactive thyroid, right? So you're going to check her thyroid levels just to see what's going on. Does she have a suppressed TSH and elevated thyroid levels? And this is pretty classic sign of Graves' disease because you're seeing that exophthalmos, right? The eye disease, the bulging eyes, along with some of the other vital signs that you have, and as well as her history. So an EKG, it's so while the patient is experiencing the arrhythmia, they're talking about palpitations, you probably will get an EKG in your exam, to be honest, but the EKG is probably going to look normal. And what they're trying to get at there are the classic signs of Graves' disease in that question, right? And then your Chem7, you're probably also going to include that since you're doing a thyroid panel anyways, but that's not really going to get back to the Graves' disease. So they were trying to make sure that you understood the classic signs of Graves' disease in that question, right? So when you're looking at questions on the board, try to figure out what are they trying to get at? What do they not want you to miss? So these are probably going to be things that you're going to do anyways, but what's going to be specific to the symptoms that she's presenting with, right? And then you also, on that Chem7, you do want to look at electrolyte imbalances, make sure symptoms aren't coming from hyperkalemia or something like that, but they wanted you to identify those classic Graves' symptoms. Okay, good job. So now moving on to the parathyroid glands. So your parathyroid glands are you have 4 parathyroid glands, and they're connected to the posterior surface of your thyroid gland. So you have 2 on each side, and you can see it in this picture here. And their primary function is to regulate the blood calcium levels. And so they release parathyroid hormone to help increase those calcium levels in the blood if it's too low. And how does it do that? So it pulls calcium from the bones, it increases reabsorption of calcium in the kidneys, and then also increases absorption of calcium in the intestines. So 3 main ways that it does that. There are 2 different types of parathyroidism. So there's hypoparathyroidism and hyperparathyroidism. So just like they sound, hypoparathyroidism is when there's a decrease or insufficient secretion of that parathyroid hormone. So you're going to see low levels of calcium, and then you're going to see high levels of phosphorus. So those are always going to be opposite of one another. And some causes of that could be in their patient's history, they might have had head or neck surgery that maybe affected one of the parathyroid glands. They could have had a thyroidectomy, right? Autoimmune disease also can cause it, genetic disorders. But basically the symptoms for hypoparathyroidism hypoparathyroidism can be on a spectrum, and they're really hard to identify. They could be anywhere from mild to really severe, but on the exam, on the boards, you're probably going to see like hallmark signs when they're trying to get at a disease process, right? So the hallmark sign in hypoparathyroidism is that tetany. So maybe you have a patient coming in, they're describing some of that perioral numbness around their mouth. They're describing paresthesia of the hands and the feet, muscle cramping. That's going to be the tetany is going to be your hallmark sign for that hypoparathyroidism. And then you have hyperparathyroidism, which is on the other end. That's going to be excess secretion of that parathyroid hormone. So you're going to have high levels of calcium, right, and low levels of phosphorus. And so there are different causes of that as well, primary and secondary. Primary is often diagnosed before signs and symptoms even come up. So you might see some elevation of that calcium on a routine blood test. And then the symptoms for hyperparathyroidism are also nonspecific. There's this little rhyme: painful bones, renal stones, abdominal groans, and psychiatric moans. So it should be on your differentials if you have a patient with frequent renal stones, maybe they have osteoporosis, weak bones. It could be on your differential if they're having nausea, vomiting, abdominal pain, vague abdominal symptoms. But the symptoms can also be pretty vague in hyperparathyroidism. Again, the diagnosis is pretty usually found incidentally. But basically, you should have these on your differentials. And as a primary care physician, you just want to make sure you're continuously looking at those calcium levels when you're doing your routine labs, right? So don't ignore all the things that you get on that Chem 7. Look at that calcium level and make sure they have adequate calcium levels and not too much, because too much is not good either, right? With that hyperparathyroidism. And then if you do suspect that it could be hyperparathyroidism, then you want to order your parathyroid hormone levels, phosphorus, vitamin D levels, make sure those are all within normal too. And then if you suspect it, then you'll need to refer out. All right, so Cushing's. So we all probably know this from our nursing boards, right? NCLEX, we have to know the difference between Cushing's and Addison. We're going to also quickly go over that. And then I have an exam question for you about how it might come up for your NP boards, because of course, Cushing's, Addison's, those are things that could be managed probably by your endocrinologist, but something you might have to flag as the primary care provider and refer out. So Cushing's, the pathophysiology again is the body's making too much of that cortisol for a long period of time. So cortisol, your stress hormone, is good, right, in acute responses. But if you're having high levels of cortisol for a long period of time, that's going to affect things like your blood pressure. You're going to have hypertension, secondary hypertension. It's going to affect your blood glucose, so lead you that person's going to be more insulin resistant and maybe lead you have increased risk of developing diabetes. And then you want to look at the causes. So if you're seeing this in a patient, have they been on long-term steroid? Have even they using long-term steroids? Maybe they have an autoimmune condition where they have to take steroids for their joints. Maybe even the inhaled steroids. I've seen that in a patient too. The inhaled steroids that they're on for a long time is causing an issue with their adrenal glands. It could be a tumor. I also had a patient who had, what is it called? It's long COVID. And so they had a lot of respiratory issues, had to take a lot of oral steroids, and their PCP sent them over to us to make sure we ruled out Cushing's. So you want to make sure that you know what Cushing's looks like. And if you suspect it, we'll talk about the initial workup, but you'll probably be sending it to endocrinology to work them up. But if the patient's coming in and they're complaining of, weight gain, you notice they have central obesity, maybe they have that fat hump between the shoulders, right? On the back of their neck there, you'll see it. It's pretty distinct. They call it moon face. So you're going to have that round, puffy face. It's going to be the pink hues on the cheeks. You're going to have that pink, purple stretch marks, right? They might complain of easy bruising, or you might have to ask. Some acne, older in age. Hirsutism, so hair growth, again, older in age, you're seeing some of that insulin resistance. Some menstrual irregularities if they're still menstruating. And then suspect it also if you're seeing any bone loss with the osteopenia, osteoporosis. But for Cushing's, definitely remember what that cortisol level does in the body. So it does affect the blood pressure, blood sugar. So you might see it in those patients with hypertension, diabetes, hyperlipidemia. You might think, well, what are their cortisol levels like, right? So the initial diagnosis, typically they're going to probably do a dex suppression test, so dexamethasone. They'll give them some dexamethasone the night before, and then they'll come in fasting in the morning and they'll check their cortisol levels. For you as a primary care physician, clinician, just know that the cortisol levels are going to be suppressed in that test. That is normal. Patients are going to kind of freak out about that, be like, oh my God, I'm not making any cortisol. But that's actually a normal result, right? So if they're taking the dexamethasone the night before, then their body's not producing the cortisol because you've given them the cortisol. So they should have the suppression in the morning. So again, this is something that endocrinologists are going to work up, but it's good to know when you get those reports back, and always read those referral notes. You'll learn a lot from them. And then the treatment is basically addressing the underlying cause. So do we need to lower those glucocorticosteroids? Look for an alternative medication for that person? Are we really pushing it towards Cushing's? Do they need surgeries or tumor causing the high cortisol level? So addressing the underlying cause and treating the cause is going to be the treatment. And then with Addison's, so Addison's is the opposite, right? So the opposite end of the spectrum. So the adrenal glands don't make enough of the hormone cortisol and aldosterone. Again, this is a rare condition. Most of these patients are going to be unfortunately diagnosed maybe in the hospital if they're having adrenal crisis, but it is rare, but something that you should be aware of and have in the back of your mind with your differentials, and certainly for your boards, you should know about. But the clinical features are also variable in Addison's, but the classic or hallmark, you're going to see that hyperpigmentation. That patient might come in complaining of dizziness or hypotension. So hypotension, right? They don't have enough of the cortisol and the aldosterone, so they're going to be hypotensive. Salt cravings are also another classical sign, and they're going to be pretty skinny, so they're going to have that weight loss despite their appetite. And then so for that, the endocrinologist is going to do an ACTH stim test. If it's an Addison crisis, you definitely want to get them over to the hospital because they're going to need supportive care and further workup to confirm the diagnosis. If it's a routine follow-up with their endocrinologist, they're going to be on glucocorticosteroid replacement. So that's not something you're going to manage because it's pretty complicated, but knowing that that's why they're taking those steroids is going to be important, and their endocrinologist should be talking to them about stress dosing to help them with different times when the body would naturally release cortisol. Since their body doesn't naturally release that cortisol, they'll be needing to take that medication synthetically to help mimic that response, right? So again, something that's managed by endocrinology, but something you should know for your boards. Okay, so speaking of, let's do a practice question. Which of the following conditions does not contribute to secondary hypertension? So remember, hypertension. Is it A, Cushing's disease, B, obstructive sleep apnea, C, renal disease, or D, Addison's disease? And this is a hard one, so do not feel shy about guessing. But I wanted to throw it out there so we can talk through the answers. And that's our goal today, is to talk through it so you get it right on the boards. You know, I thought this was a hard one, but you guys are all getting it right. And I'm really impressed. I mean, this is labeled as hard on our QBank. So yes, you are all right. It's Addison's is the correct answer. So you guys are all correct. So Addison's, again, we talked about, it's hypotension, right? Not enough cortisol and aldosterone. So they're going to be hypotensive, dizzy, weak. With all the other ones, they do cause that hypertension. So Cushing's disease, certainly with that increased cortisol, it's going to affect their blood pressure, blood sugar. So you're going to see hypertension. As well, obstructive sleep apnea, right? In a patient with hypertension, you should be asking them questions about sleep apnea. How are they sleeping? Do they snore? Do they wake up feeling rested? Do they have a headache when they wake up? So you definitely want to rule out sleep apnea in your patients. Make sure you're treating sleep apnea because it leads to a lot of cardiac issues. Renal disease can certainly lead to hypertension because of that renin response. So absolutely correct. And this is a cardiology question on the board. So you're not necessarily going to get these questions for under the endocrine category, but you need to know your endocrine disorders because they do, like we talked about in the beginning of this lecture, affect most of your body system, right? So all those hormones are telling your body what to do and when to do it. So it's going to come up even on the cardiology portion of the board. So awesome job, you guys. I'm really impressed you got that right. That's great. I thought I was throwing a hard one in there. Okay, next one. For what health condition is a person with celiac disease at risk? So this one is also another hard one. Again, we're going to talk through it, so don't panic and take your best guess. Is it A, hypothyroidism, B, hyperthyroidism, C, hypoparathyroidism, or D, hyperparathyroidism? So go ahead, take your best guess. Don't be shy. Young Ho, I love that you tried. I'm going to give people a few more minutes. Just take a guess. It's okay. Good. Madison, awesome. Good. Keep going. Come on, you guys. You can put a question mark at the end. It's okay. Good, Libby. Keep going, guys. All right, this one was a hard one again, because this is a GI question, but it comes up, right? So again, knowing your endocrine to see which would be the right one. So actually D, so hyperparathyroidism. And that's because that parathyroid gland, when it becomes overactive, remember in hyperparathyroid, it releases a lot of parathyroid hormone to help stimulate that calcium release from the bones. And then one of the ways that the body absorbs calcium is through the intestines, right? And then celiac disease, if you have damage that occur at the lining of the small intestines, you're not going to be absorbing that calcium, and there's going to be malabsorption of that vitamin D as well. So that was really tricky. So I really love that you guys tried. But yes, so you're, again, with these endocrine conditions, you're going to see it across the board. It's not just in the endocrine section. And so knowing the pathophysiology and thinking it through is going to be a little bit it's going to help you out a lot. So then with the autoimmune conditions, they're not really directly linked to celiac you're right. Somebody said because hypothyroidism, you can have an autoimmune, so maybe it puts them at more risk for celiac disease. You definitely should be thinking about other autoimmune conditions. Once one person has one autoimmune condition, they're more susceptible to having other ones. So you're absolutely right. But in this question, they were trying to get at that absorption issue. So in celiac disease, you're not absorbing the calcium and the vitamin D as well. So awesome job, you guys. That was a really hard one. That was labeled hard. All right, last one, I promise, and then we'll open it up to the Q&A. What medication for the treatment of hyperthyroidism is contraindicated in the first trimester of pregnancy? So is it A, PTU, B, propranolol, C, methimazole, or D, metoprolol? And so we talked about this a little bit. Good, Libby. Good, Madison. Good, Young Ho. Okay. You guys are getting it. You're listening. So again, with your pharmacology on the boards, they're always going to get at safety, right? Even if you're not the one managing the methimazole, you need to know that it is contraindicated in pregnancy. So you definitely want to make sure if that patient is talking to you about family planning, that they're going back to that endocrinologist. You're having them go back to the endocrinologist and talking their endocrinologist about their treatment options for their hyperthyroidism. And they probably need to be switched to PTU if they want to stay on anti-thyroid medication. Propranolol and metoprolol are perfectly safe in pregnancy. It's not contraindicated. So they do need to talk about their treatment plan for their hyperthyroidism. If they're planning pregnancy, their endocrinologist needs to be aware of it. So awesome job, you guys. You did great. That was a really tough lecture. You know, endocrine is always hard because the anatomy physiology is really complicated, but depending on how deep you want to go into it, as long as you understand the anatomy physiology, it's going to be a little bit easier to understand the pathophysiology, the abnormal, and then you will see it come up on the board. So practice those Q&As. As Morgan mentioned, the questions came from our Q bank. So please go on there and practice, practice, practice. We have a lot of good questions for you on our Q bank. We have over 1,500. We'll still do these live webinars every week leading up to our 3-day live review. So registration's open for that. Sign up for our 3-day live review and you'll get to practice. You'll get to watch those videos for 30 days after the live review is done. But practice is where you're going to learn a lot from those rationales. So you guys know the material. We're here for you. You're going to do great. I know you are. Connect with us on social media. Don't forget about next week's giveaways. That's going to be a lot of fun. And then always feel free to email us with any questions that you have, either about Archer or the boards or whatever you have questions about. We're here for you. So definitely keep up the good work. You guys are doing really great. Now I'm going to leave it open for a little Q&A. You guys can ask me any questions about endocrine. You can ask me about Archer review, about the 3-day live review that's coming up at the end of May, about our Q bank, whatever you want. I'm going to leave it open for you to ask some questions before we have to log off. So I'm not understanding the question about from Young Ho because yes, so is it a severe case of hypothyroidism? Yes. Was that your question? Because you have it correct. You're not going to see it as often again because it's really when there's slowing function of multiple organs. And so it is an emergency case. It is a high mortality, but you're likely not going to see it in clinic because it's going to be in a patient who's gone undiagnosed for a long time. But good question. And then, yes, we do provide a study guide with a review. Is that correct, Morgan?
Yes, we will have a study review, a study guide for you guys. Great question.
And like I said, you're going to be able to watch those videos for 30 days after the review. So you'll have access to all that. So even if it's something you want to go back and watch again, it's something you want to revisit, that'll be available to you. And how much is the review? I think it's just $50 for all 3 days, right, Morgan?
That's exactly right. $50 for all 3 days. One of our primary missions at Archer is keeping things affordable for you guys. We know school is not cheap and most reviews out there are pretty pricey. So we're really not trying to overcharge you. We promise it's going to be a very thorough, very, very high quality review. We're not skipping on quality. We just want it to be affordable for everyone.
That's right. Young Ho, those terms can be really confusing. You're absolutely right. But the boards aren't going to ask you, like, what is this term? So just understanding the pathophysiology behind it, you'll be fine. So don't get caught up in the terms. But yes, Addisonian crisis, adrenal insufficiency, Addison disease, Cushing's, all that can get a little confusing. But just remember what you're looking at and what the symptoms are and what the disease process is. But you guys are doing great.
A question here, Hiva, that came up was if could you explain, is there a connection between celiac disease and hyperthyroidism? And if so, can you explain that?
So I think the only connection that we talked about is they could both be autoimmune, right? If celiac, autoimmune. So once you have one autoimmune condition, you could be more susceptible to other autoimmune conditions. And the most common type of hyperthyroidism is Graves' disease, which is an autoimmune condition. So that's the relation and the correlation. So that's what we're talking about. So that's a really good question. You'll see that a lot in your patients. So again, the key takeaway is once your patient has been identified with one autoimmune condition, or if they have a family history of autoimmune conditions, you want to keep those at the top of your differential list just to make sure you're ruling them out. But that's a great question, yes.
Perfect. And one other question I saw over here was if the live review will be available on demand. If you have to work and you can't be there for all 3 days, the answer is definitely yes. It will be uploaded to your student dashboard. So even if you do join, you can rewatch it. If you miss a section, we will have it available for you. Just as soon as the review ends, we'll process the video and post it to your Archer Review student account.
That's right. It's going to be fun. It's going to be Friday, Saturday, Sunday, right, Morgan? And it's going to be all day on
Yes.
Friday, half day on Saturday, Sunday, and we're going to cover everything. It's going to be head to toe. And then we're also going to have some open discussions on Saturday and Sunday about just general practice, entering clinical practice, some test anxiety. So it's going to be a lot of fun. It's going to be myself and our whole FNP team. So you'll have a lot of great clinicians from a lot of different backgrounds. So you can ask them direct questions about their experiences and really get everything answered. And like Morgan said, if you can't attend live in person, it'll definitely be available for you to watch for 30 days. So if you're signed up for your boards in June or July, it's going to be plenty of time for you to watch all those videos and study up. Yes, and Morgan put in our pass rate is 98%, which is really awesome, right? That's something we're really proud of here at Archer. So we have a 98% pass rate. So we're here for you for the boards. We're here for you for clinical practice. You guys are going to be prepared and ready to go. Okay, so we just reached the top of the hour. So I think we're going to wrap it up for the day, but I really appreciate everyone joining. If you have any questions, again, feel free to email us. Don't miss next week's webinars and the live giveaway. Next week, we'll be talking about diabetes. So I hope to see you there. And if you think of any questions from today and you join next week for diabetes, feel free to throw the questions in there too. Sometimes you have to sit with it and think about it. But I'd love to see you next week on our part 2 of endocrine. And thank you so much for joining us here today, you guys. Have a wonderful rest of your day.